It is an honor to be here with all of you today in this beautiful place. I want to congratulate you. I think some of you are here today thinking you have a lot to catch up on. What I want to compliment you on, to applaud you on, is that you have a room full of people dedicated to pediatric palliative care. Look around this room. This is amazing. And I will tell you that in some ways you are a few steps ahead of other places. So there has never been a pediatric palliative care national conference in the United States. There's Palliative Care Conference, and we have a subgroup, but the very first National Pediatric Palliative Care Conference in the United States will happen this summer. So you are several steps ahead. So give yourself a round of applause. So I've had the pleasure of meeting some of you in Salzburg and in Prague this summer. And it is very important to me that we have communication both ways. For those of you who have met me before, if I'm not making sense, I am counting on you to tell me, okay? And I've been asked to talk about some things today which are a little bit different than what I usually teach about. I usually teach about decision-making or communication or symptom management. But I was asked today to talk about two topics. One is how my team evolved, since all of you are in the evolution phase of your teams, and also to talk about how we care for our team so we can do this important work. So I receive some support from some foundations that help fund my time to teach. We're going to talk a little bit about how we fund the work that we do, and I am very grateful to the YC Ho and Helen and Michael Chang Foundation and the Milbank Foundation for supporting my ability to be a teacher in pediatric palliative care. I also want to acknowledge that I have been at a single institution, and while I think there are many lessons I have learned that I want to share with you, you are not in the same place as me, and some of these things may be the right fit, some of them may need a little bit of adjustment, and some of them may not work at all. And I just want to acknowledge that anyone who thinks there is one solution to a problem has not studied the problem, right? The issue in pediatric palliative care is that we need to customize the care to the child and the family. And so all the things I talk about today, hear, try on, and decide if they are helpful to you. So I want to talk a little bit about how the Pediatric Advanced Care Team, that's what our palliative care team is called, evolved at the Children's Hospital of Philadelphia. I want to talk about some early challenges to program growth, and I want to talk a little bit about later challenges to program growth, recognizing that all of you are in different phases of growth, and growth is not linear. Growth comes in fits and spurts, and sometimes it trails back on itself and moves forward again, and that's okay. So I want to think a little bit about our team from 2003, 2004, when it was founded, to 2015, 2016, which is the last time we looked very systematically at a lot of data. And I want to think about it not in terms of numbers, but in terms of experience. So in fiscal year 2014, I would say we were the coalition of the willing. And we're going to talk a little bit more about that. In talking to you, in meeting the people on the modal team, you are not only the coalition of the willing, you are moving to the coalition of the experienced. And so we're going to talk about that evolution of expertise in the team. We're also going to talk about finding opportunities and moving from opportunities to sustainability. Because at the beginning, there's a lot of chances, there's a lot of what feels like risk, And it's transforming that into something that can be perpetuated and sustained. I also think we evolve in what we can offer. So at the beginning, we are the people who raise our hand and say we can help. We will try, we will help. But as a team matures, one of the things we have to get good at is not raising our hand quite as much, or at least being wise when we raise our hand. And I would argue that learning to say no is part of the evolution as a team matures, and we'll talk about that too. So where to begin? Well, most stories begin with once upon a time. The Children's Hospital of Philadelphia is the oldest institution dedicated to the care of children in the United States. It was founded in 1855, which in Prague and in the Czech Republic is a very, very young age, but that's pretty old in the United States. It has evolved into a huge children's hospital. We have over 500 beds. It is next to the University of Pennsylvania's hospital, which is the adult hospital, and while we are connected underground by a tunnel, which can allow babies to move between the institutions, it is an institution dedicated only to the care of children. And we know in pediatrics that children, while there are legal definitions, what a child is changes a lot based on their disease. There are people in their 30s with complex congenital heart disease that adult cardiologists don't understand. And there are adults who developmentally function as children. And so the experience at most big children's hospitals in the United States is that we care for infants all the way through young adults. And we care for some adults that adult hospitals say they do not know how to take care of. So I want to give you a sense of scale, mostly because my sense is that the program I am coming from is relatively huge compared to other places. And that means that when I talk about size and numbers, you should not expect to get there, because we are one of the biggest hospitals that cares for children in the United States. So over 500 beds, a lot of days of inpatient time, of hospital time, over 12,000 employees working not just at the main site, but spread over an area that takes 2 hours to drive across. And we also are a huge educational institution. So we are training 130 people at a time to become pediatricians, and another 250 people to be pediatric fellows. So they have trained either as a surgeon or a pediatrician or an anesthesiologist, and they're doing additional training. So there's a lot of people there, and I just mention that scale because in some of the numbers I talk about, you may say, well, we will never have that many, and that's okay. There are lots of programs that are much smaller that do excellent work, but this is the scale of program that I can speak to. So this is a graph that simply describes the curve of how we've grown. And at the very beginning, in the first year I described, we did 43 consults. And so I want to talk about what that looks like, because this curve is the curve that you would like to see. You are moving in the right direction. But taking care of patients here and here are really quite different. So when you look at the top part of this curve, where we are now, we are seeing 320 inpatient consults a year. We are following those patients close to 1,500 visits at a time. So there are very few children we meet once and never meet again. There are many children we meet and see for days as we manage their symptoms or navigate their complex goals. We also have a growing presence in the outpatient clinic. So we have what we call a virtual clinic. We do not have a physical space, but we go to the clinics children already come to. The children I care for and the children you care for already have too many doctors and too many clinics and too many appointments. And so we feel like for most patients, we should meet them where they are, with their oncologist or their cardiologist or their neurologist, and care for them there. And you'll notice that the inpatient and outpatient consults add up to this top number. One of the things I'm proudest of is there are now children we meet in the clinic who we've never met in the hospital. And there are many pediatric diseases where that isn't appropriate, where the best care we can provide for these children is going to happen in the hospital. But there are some children who we can meet and we can support through palliative care and through hospice who are never hospitalized. And to me, that is one of the goals that we can move towards in certain diagnoses, because a child with a DIPG, a diffuse intrinsic pontine glioma, who is diagnosed and has a tumor that will be treated, at least in the United States, with outpatient radiation, but will be a fatal tumor, doesn't need to be hospitalized for us to talk about what's important to that family, and doesn't need to be hospitalized in order to set up excellent home-based palliative care so that child can live at home and live well until they die. I think the other piece to think about is what funnels from consults to clinic to hospice. And when we started, we would have 1 or 2 hospice patients at a time. Hospice in the United States is mostly mobile hospice, as you have here. It's a separate organization from my institution, so we would partner with hospice agencies to provide this care, and we would have 1 or 2 children at a time. Right now, we average between 20 and 25 children at a time that we care for on hospice, and make close to 50 referrals a year to hospice, so about once a week. So this graph is not as helpful as I wish it was, because the colors on the computer did not want to cooperate. But it's to give you a sense that the children you see inpatient and the children you see outpatient are not always the same. So there's some obvious things, like the PICU, which is our pediatric intensive care unit, does not have an outpatient clinic, right? So there's some obvious things that will only be on one. But when you look at this, the big inpatient referring services for us, it's about 20% oncology. What you'll notice is on the outpatient side in the clinic, it's double that. And that's because most of the complicated symptom management we do is for children with brain tumors and solid tumors. And most of them, if you're thinking prospectively, you can do moving forward, and you can do it in the clinic. You do not have to hospitalize them to do it. But it means they need an early relationship with palliative care. Another difference you'll see is that cardiology makes up a bigger chunk on the inpatient side than the outpatient. So it's about 1/5 of the pie here, and here it's about 1/10 of the pie. And that's because complex congenital heart disease, as we know, mostly the severe disease we find at birth, and those kids are hospitalized. They don't tend to be in an outpatient setting when we meet them because they are in crisis at the time of birth. And you'll notice that there are some other things represented on outpatient. Neurology is 20%, pulmonology is 13%, that don't show up in the same way here. Part of that is this PICU box, this intensive care box, because the children who have refractory epilepsy who are intubated, the children who have acute on chronic respiratory failure, they sort of show up in these numbers, whereas in the outpatient setting, they're going to show up in their clinic of origin. Does that make sense to people? Okay. So all these pie charts are great, but what on earth does it mean? What does it mean when you're starting a program? Well, for us, what it meant is the first year we had a team, and I'll talk about what that team looked like. We did 43 consults, which is about 1 a week, some weeks no consults. And remember, we're meeting these children at the much later in their disease, so we're following them for a lot shorter period of time. And so when people say, I've only seen 1 patient, or I've only cared for 3 patients, that's pretty typical at the beginning. Like 1 new patient, 2 patients on hospice, that's really normal. But that evolves quickly. And so I will tell you now that it is typical that we do 1 new consult a day. Though most weeks it feels like we do no new consults Monday, Tuesday, Wednesday, and Thursday and Friday we do a lot of new consults. But we all know that's how the world seems to work. We also see about 6 children in follow-up every day. While we may have 20 children on our census, we do not see everybody every day. And we do that for a couple of reasons. One is, if you are spending the time many of these families need, you cannot see 20 people in a day. But also, palliative care needs to come in measured doses. So for some families, they need you every day. Other families need you, and then they need a break from you. And then they need you, and then they need a break from you. And so we often have families, we check in on once a week. We have families we check in on every other day. We have families that we are checking on in the morning and checking on before we leave at night, because it really depends on what they need, and that's how we determine this amount of service to provide. It means now we're seeing 3 to 4 patients in clinic a week. I will tell you just from this year, it is more than that. As we opened an outpatient clinic, and we could shift some of those kids that we were meeting in crisis in the intensive care unit to an outpatient appointment referred by their pediatrician, that is the largest area that is growing. But I will tell you, for the first 7 years of our program, we had no official outpatient program. We had 1 program, and I would see patients in the hospital, and then the oncology clinic would call, and I would run over to the oncology clinic, and then the pulmonary clinic would call and say, well, I'd really like you to meet this patient with cystic fibrosis, but they're being admitted. And I said, great, I will meet them tomorrow on the inside. I'm not coming to clinic now. And we ran to where the patients were. And when we could no longer do that in a way that made sense, because you couldn't be in 2 places at once, we said, help, and we need a outpatient practice. So that early team, that team that was seeing 1 patient new consult a week, was made up of 3 kinds of people. It was made up of 1.5 FTE, that's full-time equivalent, which is how we think about the amount of people you need, of physicians, but it wasn't just 1 physician. It was actually 3 physicians, a neuro-oncologist who was the founder of the program who did the bulk of the time, a critical care physician, a pediatric intensive care physician, and a physician who mostly does research but did complex pediatrics and medical ethics. And this was our coalition of the willing. The neuro-oncologist was right out of fellowship and trying to find her niche, and realized that this was a totally unmet need, and she raised her hand and said, I'll try. The critical care physician was someone who was a little farther in their career, who had recognized that the challenges of caring for children with life-threatening illness with more and more technology didn't always work out the way we hoped, and said, I think that the intensive care unit needs to be as part of this. And the researcher, complex pediatric specialist medical ethicist, Dr. Chris Feutner, was someone who said, I'm interested in this. And like many people in palliative care, his interest came from a personal place. It came from being the sibling, thank you. It came from being the sibling of a child with Down syndrome who developed leukemia, who died during his training. And by being a bereaved sibling, he came to this work, which I think many people in palliative care come to this work through some sort of personal connection. And it's an important thing to remember about this group. All of these physicians had other jobs too. They had some of their time doing palliative care, but they had more of their time doing their primary subspecialty. And that was one of the ways we built trust in the institution. Because when Tammy Kong, our neuro-oncologist, when the oncologist would call Dr. Kong, they were calling someone they had trained to be an oncologist. So even though she did this palliative care thing, she was one of them. Same thing in the intensive care unit. They were calling a colleague. They weren't calling some other team who didn't understand what they did. And this was really important in the early phases, and we'll talk a little bit more about that. What I want to focus now on is the rest of the team, because palliative care is an interdisciplinary team. Anyone who says they have a palliative care team because they have a physician who is interested and practices palliative medicine has a palliative medicine physician, which is an incredible resource, but does not have a palliative care team. To have a palliative care team, you need an interdisciplinary team, and that's classically defined as nursing, social work, and a physician working together. I want to talk a little bit about the development of that piece of our team, because I will tell you that the growth you saw from 43 consults up was not driven so much by the physician growth. It was dictated by the growth of the comprehensive services we could offer families. And so I would beg you, as you are investing in this in your country, to think about the interprofessional team you need to do this well. So at the beginning, what you need is a coalition of the willing. You need the people who raise their hand and say, I am passionate about this and I will try. And this is where you invite interested individuals to come to the table. And some of them may be interested and have a really different view of palliative care than you do. Invite them anyway. Okay? If they want to talk about palliative care, they should be at the table. You need to include administration, and I think you did a beautiful job this morning showing a range of people from your Ministry of Health and from your government and from academic institutions who are working together. But you need everybody at the table. One of our most powerful advocates in pediatric palliative care is someone who was a lobbyist, and that's a bad word in the United States. These are the people that push for laws to be passed and influence members of Congress. But this lobbyist was passionate about pediatric palliative care, and she has a microphone to the people that make decisions. She's an incredibly important ally. She does not know much about the medicine, but she knows a lot about getting voices heard. She needs to be at the table. The other thing you need to do is share your cases and share your successes and share your struggles. And for those of you here who are with your team, that's amazing. You found some of those people. But I bet some of you are here today and you feel like a team of one. You feel like an island. And what I want you to recognize is that this group, this is your team. You have a coalition of the willing at a national level, and that is amazing. So you can be this person, these people to each other. The The other thing that I learned from Tammy Kong, who founded our team, is you need to feed people. And you laugh, but food gets people to show up for things, right? And food in different places and different cultures has different roles. So for us, getting people to pause in the middle of the day is really hard. But if you feed them lunch, they show up. And so we fed people a lot of pizza, okay? And people knew if they came to the Coalition of the Willing meeting, there would be lunch. And it was in the same place, in the same room. But don't underestimate the power of the small things to pull people in. Because sometimes knowing that you are going to be able to sit down for 15 minutes and eat lunch is what makes you go to that meeting. I think you need to think about your Coalition of a Willing in sort of two spaces. One is your weekly IDT, the interdisciplinary team. And I will try to not use abbreviations, but if you see IDT, IDT is interdisciplinary team. It is the core unit of function of a palliative care team. The IDT needs to be meeting with each other to talk about clinical cases, to make a safe space to discuss changes and discuss challenges they're facing. But the thing is that if your IDT is one physician, one nurse, one social worker who work together all the time, you might think, well, we have IDT all the time. It's called Monday, Tuesday, Wednesday, but that's not what I mean. You need to be doing this in a public space that allows people to come. You need to have IDT where you're inviting students, where you're inviting the hospital administrator, where you're inviting the skeptic from the pulmonary department who's not sure if they want to consult you. And you need to have this meeting so that people hear what you do and they hear how you think about problems. The other thing is IDT has to be a safe space. So it needs to be a space where people can say, it is really hard to walk onto the 7th floor because I get the stink eye from the nurses every time I walk on there and I feel bad. Or Dr. Jones from neurosurgery is really being difficult to work with. So it needs to be a place where people can honestly talk about what's hard and people can also celebrate things that go well. And that shared space, and every time we have team, my team says, you know, this is a protected space. What happens in this room stays in this room. We will have that conversation even if the administrator is there, even if the students are there, but we name it as a safe space. And culturally, I do not know if that works for you as it works for us, but for us it has allowed us to have conversations that other teams don't have. It allows us to, we say, name the elephant in the room and talk about why it is hard to do the work that we do. The other thing you need with your Coalition of the Willing is a steering committee. Now, the steering committee does not need to know all of the details about all of the patients, but they are the people helping you develop your vision. They are discussing program development. They are you're inviting palliative care stakeholders, and you need to record these meetings. You need to take minutes, have someone take notes, and if someone who's regularly supposed to be there can't come, you need to share those minutes. You need to document what you're doing. Because one of the things that becomes very important when you need to say, well, what is your palliative care program, is you need to be able to say, this is what we're doing. And official records of doing count. So if you have a team that has been meeting and there is no record of their existence, and all of the patients you've cared for have died, you can't even find them in the hospital anymore, it's very hard to say what you do. But if you can say, oh yes, in January 2018, we discussed 3 patients and one of them went to hospice, and in February, we discussed 4 more patients, and in March, We had a guest come from physical therapy who talked about making homes more accessible when children have physical limitations. You document all of the learning and thinking you're doing, and it helps legitimize what you do. The other thing you need is a mission statement. How many of you have teams that have sat down as a core group and said, this is what we do? So this is really important. It's really important for the people at the table to say, this is our purpose. Our mission statement says, the CHOP Pediatric Advanced Care Team aims to relieve suffering and improve the quality of life for children living with serious, potentially life-limiting conditions and their families. It's one sentence, but it is what guides what we do. If you have a team or a coalition, you need a guiding principle, and you probably have some, but it's time to formalize them and write them down. Again, things that last have demonstrated their purpose and can name it. And if I ask this person and this person, they can give me the same vision, which is why developing a shared vision and writing it down is so important. So when people say, how do you keep a social worker, a nurse, and a physician, or at least part-time of several physicians busy if you're seeing one consult a week? That does not seem like a very efficient way to use staff. And I will tell you at the beginning, it is efficient in a different way. It is not efficient in terms of staff resources per patient, but it is incredibly important for building your team. So one of the things is you're starting out. And so most of the people doing this work are learning the work as they're doing it. They are figuring out how to be a pediatric palliative care social worker, nurse, physician. And you have the gift of time to spend with families. We get better at this as we go, but the hours you invest with families early on and the hours that families will generously let you be with them reap rewards. The other thing is you are teaching, and you are teaching, and you are teaching. You're teaching anyone who will let you teach them. If the medical school has students, you say, sure, we'll take them. We can't take 17 of them at once, but we will take one at a time. Keep sending them. If the nursing school says, do you have any opportunities? You say, yes, send them. If a community group asks, what is pediatric palliative care? You say, can I come tell you about it? Because you need to be getting the face of palliative care out there, and you need it to not be frightening. You need it to be just one of you. And so using this time when you are not super clinically busy to teach is developing the infrastructure that will grow. Last night when I was having dinner with some of you, you asked me how long does this take, and I told you 10 years. There's a couple reasons why I say that, but one is that when you train medical students, then they become residents, then they become attendings. And if a medical student cannot imagine a world without pediatric palliative care, or without palliative care in general, when they become the boss, they call you. But it takes time and investment to grow those folks. So if you have to pick who you're going to teach, if there are senior people that want to be taught, you must teach them. But the people to spend your time with are the earliest people in their training, because they are the people who will become the decision makers that you need to continue to invest in palliative care. One of the things my team talks about in the beginning is look for ways to be helpful. There are times when we would get consults that did not seem appropriate palliative care consults. Does this child have a life-limiting illness? Well, they're in the hospital. Okay, well, what's their diagnosis? Well, they had a VSD repair and the family's really angry and they don't speak English and they're taking up a lot of time, so can you come be helpful? So that is not a good use of a palliative care team per se, but it may be a place where you can invest resources. And you need to be careful, but sometimes when people call you at their wits' end because they're really frustrated, new eyes are helpful. And so there are times when we walk into situations and we are the people who can sit down and listen and not judge and have some time, and then we can walk away from the situation and say, actually, the reason this family is so upset is because we haven't done a good job communicating medical information to them. Or this family is really upset because they're terrified because they misinterpreted something that was said by someone because people were not using an interpreter when they should have been. Most of the dysfunction that happens in hospitals is communication related. And one of the things we pride ourselves in is being good communicators, being good listeners, being non-judgmental, and being able to sit in a space where someone is angry or sad and hear them. And so if you think about that concept of palliative care, the excellence in communication, many of these not palliative care because of the diagnosis actually are really wonderful places for us to use our palliative care skills. One of my mentors calls this being the ninja, because you go into the situation that everyone has deemed impossible to fix, and the parent's not yelling anymore, and things have calmed down because you've taken time and made space. And so think about, in your own institution, if you get a call from an unlikely place, is it worth your investment of time to use your expertise in communication to help these families? It makes a difference for the family, regardless of the diagnosis. And if it earns you trust, that is invaluable. And then the next time you may get a call about the patient that you really are hoping to see, instead of the patient everybody is panicked about. Does that make sense? Okay.
I have a line at the bottom that says, don't quit your day job.
Remember that who you are coming into this, a social worker, a psychiatrist, a sociologist, intensivist, is very important in building the bridges for palliative care. And so make sure that you continue to be seen in your institution as who you came from, as well as who you are becoming. Because they are much more likely to reach out to you as the intensivist colleague if they feel like you are one of them. And I feel like that's one of the secrets of palliative care, both in their interdisciplinary nature and in the crossing professions of the medical field, is that if you build a diverse enough alliance, somebody on the team feels approachable. And it may not be me, but it may be the chaplain or the art therapist or our nurse who has worked in every department in the hospital before coming to see us. So it is important to raise the profile of palliative care. That is your job at the beginning when you are not clinically busy, is to be the best of palliative care in teaching and in your presence in the community, and take exquisite care of those patients. I want to transition into what changed when that graph started to tick up. And as I told you, it wasn't that there were a lot more doctors. So in 2014, we had 1.5 doctor equivalents divided over 3 people. In 2009, it was up to 5 doctors, but only 1.8 full-time time. So everybody else was doing other things. in the intensive care unit, in the NICU, in complex peds. But what grew, and it's hard to see on here, that we had gone from 3.5 people to almost 9.5 people, is the rest of the team grew. So we went from one nurse to an advanced practice nurse, so that's a nurse with prescriptive power, and a nurse doing case management. This nurse got her advanced practice degree, so moved into here, and we got another nurse who is an expert in community resources. Our social worker stayed, but we added a spiritual care provider, initially part-time. We added an art therapist, part-time. We added someone who was exclusively responsible for bereavement. We added some research, and we added a fellow, a pediatrician training to be a palliative care doctor. So most of our growth was in learners and in our psychosocial team, and that is what allowed us to take care of more patients, not more doctors. I want to talk about the value of the expanded psychosocial team. Each discipline brings its own gifts and its own perspective. As the number of patients you care for grows, so does the weight, so does the sadness. And it is really important to have that spread around. The transdisciplinary approach, and in the United States we think about transdisciplinary as I am trained as a physician, but I need some basic competencies in spiritual care, in assessing psychosocial resources and supports. Just like my chaplain needs to be able to recognize when somebody's in pain, and then we call each other, and he says, have you been to room 3 because you need to get there? Or I say, you know, Dexter, I'm really worried about the existential suffering this mom is having. Can you see her today? And so having team members be able to recognize what is going on for the patient and then get the appropriate provider allows you to expand your scope so that you don't need to lay eyes on everybody every day. But if your team is laying eyes on them, you can triage. The other thing about increasing the psychosocial team, the interdisciplinary team, is it increases the education of the team itself. So when I hear from my art therapist how she is working with the siblings and how they are processing things, I am learning valuable information that helps me take care of the primary patient. And one of the things I love about palliative care is the humility of who's at the table. I'm going to skip over this and talk a little bit more about some of the other pieces. So this is a candlelight service that happens the second weekend of December of every year. Last time there were 1,300 children's families there. You only are seeing part of the candles, each representing a life lost too soon. But the ability to do this for families takes a lot of coordination, but is also incredibly valuable. Parents of bereaved parents will tell you that they figure out how to continue to go on, but they do not ever recover from losing a child. And so there are people who lost children decades ago who continue to seek these sorts of events because it gives them meaning. I want to come back to this concept of why palliative care is unique in medicine, at least in the United States, which is that, and I conceptualize it as the round table. In many disciplines, the physician sits at the head of the table and is the boss. In palliative care, there is no boss. And that does not mean there is not a structure. That does not mean there is not a leader. There does not mean there isn't someone who is responsible for hiring and firing, okay? There's a boss. But in the care of patients, we are all equal at the table. And it's because every patient needs something different. Sometimes they need my medical knowledge of symptom management. But sometimes they need to connect with our social worker, or they need to connect with the chaplain. And it is incredibly important to recognize the voices of everybody at the table. And one of the things I will challenge you to do is to make sure everyone at your table's voice is being heard at the same volume. The thing that let us grow from our initial 43 to 80 and actually break 100 was more staff, but not more doctors. So we've talked about the coalition of the willing, moving towards the coalition of the trained and experienced, and recognizing that is not just medical expertise. We're going to talk some more about opportunities and sustainability. So you need a growth strategy. And one of the ways to do this is to not think in quantum leaps. I need another doctor, I need another social worker. It's how do I get another little part? So our team, and I don't have it broken up year by year, but our chaplain went from 0.4 to 0.5 to 0.6 to 0.8. And those increments were much easier to negotiate. Well, if we had a chaplain that worked 3 days a week, we would have been able to meet the need that you are saying you have. So slow and steady is a very nice way to grow. And in an institution that is big, you may be able to share those people. So our chaplain wasn't working only 2 days a week. It's just his time was split. Just like our art therapist, her time was split. And so over time, we just sort of took over more of them and more of them till they only worked with us. So that is one way to think about resources, that you can't have the whole resource, but you would like to have an art therapist that can go to the home once a week and help siblings. You get it a piece at a time. In that coalition of the willing, the people who raised their hands and said, I am really interested in this work, those are the people at the table that you ask first, who say, I would love to do this work. But the other piece is you don't let people do work for free. Because if you allow someone, and many of us, myself included, have raised our hands and done something for free. But if you allow your institution to think that they can have this for free, they will assume they can continue to have it for free. And then you have people who are working really hard and not getting credit for what they do. So even if it's buying 1 day a month, you say, in order for us to do this, this is what it's worth. The other thing is shoot for the moon. Ask for the full time, and when they say that's impossible, say, well, what if we could have 2 days a week? Could we do that? So shoot beyond and ask beyond what you think you will get, because maybe when you actually propose what you need right then for your smaller group of patients, you'll get it. The other thing is people vote with their feet. You know, when we had the coalition of the willing, and there were consistently people from spiritual care showing up, we worked really hard to get a paid spiritual care advisor. When we had people from PT and OT who initially, physical therapy and occupational therapy, who initially showed up, we thought, this is great, but then they sort of drifted away. And so while we still value those services and tap into them, we didn't work as hard to get them there because there were people who were sitting in front of us who really wanted to be there, who really needed to be there. And so sometimes the people you are working with help this process for you because they keep showing up and they keep raising their hand. So don't work too hard. Work with what you have in front of you. So once you have your coalition and you're growing, then you need to figure out how you create that stability. For us, that meant adding that fellowship, adding that training program. It also has slowly meant transitioning away from our physicians who raised their hand and said, I'm interested in this, it's important, to physicians who did that, but also followed through and got their board certification for this. Not every area has board certification, but in social work and in nursing and in other things, there are advanced certificates and training, and looking for people who are seeking those things is a very good sign. But what it allows you to do is when the institution says, well, how is this team different from any other team in the hospital? You can say, well, this is all of the specialty training people have done to get there. It may be a formalized degree, it may be coursework, it may be blood, sweat, and time being on a team. But being able to say this is what this team has done to become what it is valuable. One of the things that has transitioned in our team is we now only hire people who have advanced certification or experience. That was not true before. When I started on the team, I was a very interested pediatrician who had some experience in symptom management from oncology. But I was there and I kept showing up, and they said, I think you're one of us, and they mentored me, and they sent me to courses, and they taught me, and I evolved into being a palliative care physician. But if you're early, it's okay. It's okay to mentor people through that role. But at some point, you will reach a critical mass and you will say, okay, this is the gold standard to which we will hold people. And that's a hard time because you are all of a sudden making your very big tent a little bit narrower. I've talked a lot about education, but I want to highlight a couple of things. First of all, early in the year, or early in your time, you are sending people to learn. You're sending them to regional and national and international meetings to learn. And then you realize, or they realize, that they actually know a lot, or they have a unique gift to offer. And then you need to send them so they can teach people. And there are people in this room who are ready to do that. You're doing it here today, but when the European Palliative Care Congress comes up, people need to be putting things in for that. You are ready to do that. You have filled a room of pediatric palliative care people. You are ready to teach. And also think about the other things. I know you've had LNEC here. There's something called EPIC, which is for physicians, sort of like LNEC. There's Vital Talk, which I've talked to several of you about. There's the Salzburg seminars. These are all places you can use to teach your team. We've talked about why you need to raise your hand to teach. When you realize that you have too many patients for you to be doing all the teaching, it is time to mentor new teachers. It's time to say to the person who's raised their hand and said, I'm a new PICU nurse, I'm really interested in palliative care, but I don't know anything. Say, I'm gonna teach you how to teach this. And then you're mentoring rather than doing primary teaching. I'm gonna skip over this, but to just say that we have developed the fellowship, but we've also developed courses for medical students. And the most recent thing in our armamentarium is we're developing a psychosocial fellowship. There is no training for art therapists or chaplains to do this, so we're gonna try. I don't know what it's gonna look like yet. I have a meeting when I get back with my psychosocial team to map out our hopes and dreams for it. But you can continue to invent places to teach people about this work. And then your community, and we've talked about reaching out to the community, but part of it is reaching out to things that are already there. Part of it is creating a community, which you are doing here today. After you've created the community, then you start figuring out how the community starts teaching others, right? So you're teaching each other right now. It's how do you teach at schools? How do you teach on college campuses? How do you teach the rest of the world what you have to offer? So in my mind, and I'm a little biased because I'm an educator in addition to being a doctor, you need to know who wants it, who needs it, and you need to do as much as possible. I want to talk briefly about philanthropy. Funding in the United States is very different than it is here, but the generosity of people in small and large doses has really helped our program to grow. We have a development office where people fundraise for the hospital. If you have something like that, either at your institution or in your community that does fundraising, meet with them. There are times when someone has experienced the loss of a child, they often are passionate about it, and that passion can take lots of forms. And being able to harness that for resources is an invaluable thing. The other thing is know what your wish list is. If you're a program, you should be able to answer the question, what would you do with, and my check money knowledge is no good, but with 500 or 1,000 or 10,000 or $1 million, right? You should know the answers to those questions, because if someone says to you, what would you do with this? You should be able to coherently answer the question. It's like having a mission statement. You need to be able to articulate it clearly. So have a wish list. And the wish list shouldn't be your wish list. It should be your team's wish list. Because I can tell you, my social worker can take a relatively small amount of money and do an incredible amount of good. And so your team may actually have some of the best ideas of how that money can be used to support the work of palliative care. The other thing to know is about grateful families. And this was something that terrified me early in my career. And I had a family that taught me to be better. I had a family whose child was dying of AML, who wanted to talk 50% about symptoms and how their child was doing, and 50% about how they were going to raise money to support palliative care. And it was really weird, because I was not used to talking about money. I was certainly not used to talking about money to a parent of a dying child. But what I realized in that interaction is, for this family, that was part of their grieving. Part of their grieving was figuring out how to honor their child's legacy, and we needed to do that while he was alive. And that family has gone on to sponsor in some big and small ways our team. So don't be afraid if someone says, how can I help your team? Ask, the answer in palliative care is always to answer a question with a question. So tell me what you mean by that. And sometimes it's, can we donate toys? Sometimes it's, well, I run a poker tournament and I'd like to donate the proceeds, So capitalize on those things, but don't be afraid to talk about money. We talk about children dying, we can talk about money. We've talked about charitable foundations. The other thing I want to give you permission to do is to try new things, even if they won't work, and even if you only have funding for a year. When my team started, they had funding to fund a social worker for 1 year, a nurse for 1 year, and a physician for 1 year. My boss said, I can't do this with one physician. One physician cannot cover 52 weeks a year, and negotiated up so that so she would not be on call all the time. But by proving the value of this service, and by being transparent with the folks who stepped into those positions, that this was temporary, it was gonna happen, and we were gonna make the best of it, they grew a team. So while we all would like funds that last perpetually, It is okay to take funds and make the best effort you can. And if you've done a good job and you've proven your worth, people are much more likely to continue to fund you. I want to just talk for a minute about the strategically learning to say no and learning to what's important. This is Madeline Bell. She's the CEO of our hospital. I need to know what Madeline Bell thinks is important, which means two things. One is I have to meet with Madeline Bell periodically, but I also need to be aligning what I'm doing and what my institution prioritizes with the work of my team. And so if you don't know what your department chair or your institution or your Ministry of Health thinks is important, you need to know those things because there's probably some synergy, and that's the space you want to be working in. We've talked about that. And the final thing I'll say is about data. So when we are at the beginning phases of things, we think about all the work we need to do and all the patients we need to care for. We often don't think about the information we need to collect. And I am happy to talk with you more individually as this conference goes on about what kinds of data, but recognize that in order to report on what you do, you're going to need some basic information. You're going to need to know what kind of patients you're caring for, and I've already heard you talking about that. You're going to need to know what their utilization looks like, what this experience of the family was. And all of these things are driven by what's important. If your hospital says the experience of the patient and family is most important, that's where you need to be collecting your data. If they say we want to demonstrate that these children use less hospital resources, that's where you need to be collecting your data. But you need to think ahead, and you need to talk to people as you go, so that 5 years later, when people say, well, how do you know that you made a difference in this metric, that you've collected the information to be able to do that? So I want to thank you all for your time. We're going to talk a little bit more later today. I will make my slides available to Jiri so that you can have them. And I will make sure my email is on the bottom. So if you have questions, I am an ocean away, but email works really quick. So thank you so much.